We just want to take this opportunity as we wait for the rest of the team to join us to thank Francine Coben for helping us with the organization of the webinar. We are really so thankful and we are looking forward. And when you look at the background, it's definitely going to be something that will benefit all of us.
Yeah, I think so.
Thank you so much.
So I think I'll just get started. It's 5:04, and I can start my introduction, and if any others will join.
Maybe I could try
please.
to introduce you. I don't know how good I can do it, but let me try.
Please.
So this evening, we are privileged to have Dr. Caroline Driessen. She's a plastic surgeon at Amsterdam University Medical Center. And she has really focused in the past 6 to 7 years in microsurgery, especially reconstruction of the extremities and reconstruction of the breast. And she is also very much interested in reconstruction of the head and neck, the deformities, especially after large tumor excisions, and with emphasis especially using the IDC, IGC imaging, indocyanide. She also has a lot of interest in Africa. She has actually visited most of the countries and helped us with the surgeries. And we are looking forward to her visiting Uganda also as well one time. So, Dr. Caroline, you're welcome.
Thank you very much, Dr. Titus. And I was very privileged to meet you here in Amsterdam. And the one thing that now comes to my mind is that you said to me, I look so much friendlier in real life, especially without my glasses. So I take them off now, so we can get it started.
Please.
So thank you for this opportunity, because the facial nerve is my favorite nerve, and that's why I very much enjoy talking about it. So I like it that today we have this session of the Interplast meeting to focus on the facial nerve and on facial palsy. And we have approximately 45 minutes to have this presentation. And if something is your hobby, there's a lot to tell about it. So please interrupt me if I go too fast, or if I'm presenting in too much detail. And let me see if I manage in time, and otherwise I might speed up a little bit in the end. And now we have to see, is it working? Yes. And I think it's always good to have mentors early in your life. And I had them first when I was a resident in Rotterdam. And the left photo you see with the sunset, that's Rotterdam, the harbor of Rotterdam in the background. And Professor Mark Moreau was one of the plastic surgeons there, and he's also a reconstructive surgeon. And he focused already during his fellowship on facial palsy. And that's how it caught my interest. And then after I finished my residency in Rotterdam, I went to Sweden. So in Sweden, sometimes it's snowing. Most of the time it's not, especially not in Uppsala. And Uppsala is the hospital where Andres Rodriguez is working. And he is a Spanish plastic surgeon. And he now works in Sweden for a long time already. And he was my supervisor during my fellowship. So I was also very happy to learn a lot of him. So it's nice to gather interesting people around you. If it's junior people or senior people, that doesn't really matter, but it's nice to be surrounded by inspiring people. So that's also the good thing of these meetings, I think. So Andres Rodriguez, he also wrote this book about facial palsy. And I think it's really a very nice work. It's not so thick. It's like 2 centimeters thick. But it's a really good book if you're interested, especially in the reconstructive surgery of facial palsy. So it describes several techniques, and I think many experts from all around the world are included in the several chapters. So it's really a book that I can recommend. And often when I continue doing reconstructions, I take a look back into this book because there's always something new to learn. The other thing I want to mention is that I don't have any disclosures, but I think it's important to be curious. So read this book. And also we've set up this course and I want to show you this photo. This is a photo of a 3D printed model. And there's the other structures, the anatomical structures are made by clay. And that's a course we ran last November here in Amsterdam. And it's really nice to sculpture really the anatomy yourself. So be curious and be hands-on, and I think we'll all be better surgeons if we keep on improving what we know and what we can. So why is the facial nerve my favorite nerve? Well, let's see if this movie works. Here we go. I think it's really fabulous that this one nerve can do so many different movements of your face. And I'm not asking you to do this now live for the camera, but maybe tonight take a mirror and try to move all those different muscles. And then imagine that these movements come from one single nerve. And I think that's just amazing. Let's see. But there's other things about this facial nerve, because this facial nerve, it's a cranial nerve, but we have more cranial nerves, of course. So why is this my favorite nerve? It's also because there is a voluntary movement. For example, if someone asks us to smile, we can smile. But also the crying, of course, that's emotional. And then there's also a branch going to your the glands for salivary. So it has many different function. And I think it's amazing that all comes from this one nerve coming outside the foramen. Also, this nerve has in total 20 muscles to innervate, and that at both sides of the face. And of course, it has this cross link in the brain. And I'm not going really into the parts of the brain, but it's why it's, I think if there's a cross link, meaning that the function is protected by dual innervation, I think it's very important. So, of course, a cranial nerve starts intracranially, so it starts in the pons, and there are the nuclei of the several functions of the facial nerve. And then there's an intratemporal part, and that's the part which is inside the stylomastoid foramen. And that's also already where some of the branches go off. For example, the branch that goes to the stapedius. And there's also the chorda tympanica, which are the branches that go to your salivary glands. And also the branch that goes to your lacrimal gland. So most of this parasympathetic function comes off from the intratemporal part. It may be damaged, for example, during trauma cases, when there's a fracture of the anterior skull base. And then we come to the extracranial part, and that's also the extratemporal part. And that's where those 5 divisions come off. And that's the part most plastic surgeons know best. You can see that in the figure. So you see the pons up, which is the intracranial part. And then you see the stylomastoid foramen. And then there's the internal auditory canal. And remember, that's the part where all those parasympathetic branches go off. And then it leaves the intratemporal part and goes to the extratemporal part. And that's then where those 5 branches come off. So this is where we see it now, the 5 branches after it comes out of the foramen. You have the main trunk, and then it divides. It goes to the temporal branch, zygomatic branch, buccal branch, marginal branch, and the cervical branch. And then also, which is a little bit less known, but it's important to realize, is that there's a few more nerves from the extratemporal part. And this is one sensory nerve, which is the posterior auricular nerve. It may be involved in patients who have headaches caused by neuralgia of this nerve. And there's also 2 branches going to the muscles. Those muscles are not visible in this image, but I can show you perhaps later in one of the following figures. But it innervates the posterior belly of the digastric muscle, and most importantly, not the anterior belly, because that's innervated by the trigeminus nerve. And there's a second nerve, it has a little second muscle, it has quite a similar course, which is the stylohyoid muscle. That's also innervated by the facial nerve from the extratemporal part. And then I take you a little bit to some nerve regeneration in general, because it's important to notice that nerves heal notoriously bad. And in the Netherlands, most plastic surgeons also treat hand trauma. And I know for many African countries, the plastic surgeons also do. And there are, of course, some comparisons to be made. And one of those comparisons is that the nerves, they heal very bad. The benefit of the facial nerve is that the distance from its origin is not so far. So it's different, of course, if you have a leg with an injury as compared to a facial nerve with an injury. But still, it's important to realize that the wound healing and the nerve regeneration is really slow. And in specific cases, for example, people who have radiotherapy, and that's the patients that I see a lot because of head and neck cancers who often receive radiotherapy afterwards, there's even a prolonged wound healing of an already bad wound healing. And what we notice is that there is a loss of axons. So the nerve will regenerate, but not all the axons will survive. And so thus they will not all be functionally. And the sooner you repair a nerve, the better it is. So if you delay your repair, there is less regeneration of the axons. And if you have less axons, there is less function. Also, if you delay your repair, for example, in a trauma case with a cut in the cheek, the sooner you do it, the more likely you will be able to find the edges of the nerve and get them together again. Because a nerve has elastin in it, so once it's cut, it will retract. And the longer you wait, the harder it is to get them together without an interposition graft. But also, the longer you wait, in the Netherlands, we use nerve stimulators. And you can't stimulate a nerve after a few days of going through an injury. So you need to not postpone your repair once you want to use a nerve stimulator because of the Wallerian degeneration that will occur in a few days for the case of the facial nerve. So it's quite interesting if you take a look at this figure. It's by a group from Vienna, and I really like it because they also make this comparison to the hand, like I was previously saying, and which I think for a plastic surgeon is really interesting. And you see there are much more motor axons in the facial nerve as compared to all the three radial, medial, and ulnar nerve to the hand. And of course, the sensory function of the hand is also quite important. But in the facial nerve are approximately 10,000 motor axons, and that's twice as many as go to the hand. So if you compare for the movement of the face, you have twice as many axons. So that means it's an important muscle, important nerve. If we then compare it, for example, to the brachial plexus, there are 10% motor nerves, motor axons of the 350,000. So it's like 35,000 axons as compared to the 10,000 of the facial nerve. And for example, for the radial nerve, it already becomes much less. And in gray, I put down some of the donor nerves, and I will come back to that later, but it's good to have in mind how many motor nerves, motor axons, are in the facial nerve. So I take you a little bit also to the topography. So I just showed you the architecture, and now I show you the topography of the nerve. And you see also the branches that I was already mentioning. Here you see the sensory branch, the posterior auricular nerve coming off. And then you see the muscle branches, for example, to the digastric muscle. And then you see this main trunk with its 5 divisions. And what you see if you look under the microscope in real high resolution detail, you see that there's a twist in the nerve. And it's important to keep this in mind because as you can see, when it just leaves the foramen, the blue part, which will be the upper division later on, is still on the lateral aspect. And later on, there's a 45-degree turn, which means that the division, which will go to the the cranial part of the face, is twisted around and goes more to the cranial side of the position. And then you can even divide already this main trunk in those 3 divisions. So I was just mentioning the upper part and the lower part. You see here in green the cervical facial part. That's the part going to the marginal branch and to the cervical branch, so the lower 2. And then this upper part, which started at the lateral side and twisted 45 degrees until this positioned up. That will be divided for the lateral part going to the middle aspect of the face, so to the buccal branches. And then you have the medial part, so that's the yellow bit, and that will be going to the zygomatic branch and to the temporal branch. And if you suture a nerve, try and see if you have an oblique cut to really make this sutured in a good position. Because if you suture it in an odd position, there's a bigger chance, for example, of synchonesias. Synchonesia is the movement of parts of the face, which is not normally innervated by the facial nerve, but with abnormal wound healing of the nerve, there may be odd movements of the face at moments that you would not like to have it. So it's good to keep this topography in mind if you need to suture a nerve very proximally. So this is again together. You see here the twist there. It was on the lateral side and then a twist up. And then it is divided. The upper part goes to the upper parts of the face, and the lower part, which started immediately in red, will be going to the marginal branch and to the cervical branch. So then, having this anatomy in the back of our hand, I want to continue with facial palsy. Let me do a time check. So we have like 30 minutes left to go into the facial palsy itself and to the surgical solutions to it. So if a patient comes to our clinic, I always try and think of it to make the problem, which is quite complex in the beginning because you see some movements and some branches are not moving. I try to make it easier. So I try to make it in smaller problems. And the first thing I ask myself, is there a chance of recovery? And the recovery depends a bit on what the cause was of this facial palsy. So if the facial nerve is continuous, for example, in a Bell's palsy, nowadays we see an idiopathic facial palsy, but it used to be a Bell's palsy. So most of the time it's a viral cause of facial palsy. Then we know the nerve is continuous. If someone comes with a cut in the cheek, for example, actually we don't know if the nerve is continuous. It could be continuous and that there's a lot of bleeding and the bleeding causes neuropraxia. It could also be a problem with the nerve being cut. Then you have to go and see, actually, you have to explore. If we have a case, for example, of parotid cancer, then you often already have a guess before surgery that there will be damage to the facial nerve. In what extent, you're not sure. Of course, they try to peel out those branches as good as they can, but it's most important to have a radical excision of the tumor. So then you know the nerve is cut, for example, when you start a surgery. And then also be aware if this injury was caused very shortly. So if the patient is presenting now, there's no Wallerian degeneration, meaning that you can stimulate the nerve. But if it has been lasting for more than 3 days, it's harder to stimulate the nerve. I think for extremities it's quite a little bit slightly longer, but for the facial nerve, we think of the 3 days, it's very hard to stimulate the nerve. To try to repair as soon as you can. For example, this is a case of someone who had a facial nerve trauma. So you see those stitches were not done by a plastic surgeon, but it was done by an emergency doctor because of a lot of bleeding in this cheek. So they put in many stitches, many thick stitches to control the bleeding. And then we were consulted after that. And that was 3 days ago. So we were on the edge of when the nerve is when we were able to stimulate the nerve. And when we evaluated the patient, he clearly had a drop of the corner of the mouth. So we had a suspicion of nerve injury. And we decided at that point to take him to theater and to do an inspection on the inside and to see if we could find a nerve. And in this case, the nerve was just intact. So there was no injury to the nerve other than neuropraxia. And that was probably caused by the big hematoma that was involved in this area. So we didn't have to do anything else instead of rather than suture it very nicely, very neat. Here you see in more detail the continuous buccal branch. This case, for example, it's a case of one of my colleagues. This was also an emergency case. It was also not really time to do a good evaluation of the patient, but you see here that 3 of the branches were cut. So what you can then do, because the injury was caused that same day, there was an exploration and you can suture it with micro sutures. And we use like an 8/0 nylon to suture it. And I do those cases with my goggles. So I don't use a microscope for it, just by goggles. But I think it's a little bit hard to do it without the goggles. So magnification would be good to get a better view if it is available, of course. It's always hard if once you have found a nerve, it's clearly there, but once you have not found it and you have to go through this injured part of the body, it's always a little bit hard to find it. But nice dissection and a lot of rinsing will help you with that. This is another patient. I will come back to him later. So this is a patient who had an injury of the anterior skull base. So there's a fracture at both sides, actually, which was a little bit less severe on the left side. And then he went to the ICU, and there was not a lot of attention for the function of his facial nerves. And when he woke up from being intubated, we found out it also was a facial palsy. And that's when months later, they sent them to our clinic when there was no spontaneous improvement. And it's always a bit hard for those cases if it's good, if you already notice facial palsy early onwards, if you need to do a surgical decompression. So for some diseases, and sometimes for trauma cases, it's considered, should we do a surgical decompression? But because you have to go all up to the anterior skull base, many people find that the risks of the surgery, which is mainly cerebrospinal fluid leakage, are not they're worth taking, and the recovery, which is only like 25% better than for expective cases, is not worth it. And the research about it is also very limited. So for most surgeons and ENT doctors, plastic surgeons, it's not considered to do a surgical release. Also for patients, it's always important to consider doing a nerve investigation, an EMG. And it is useful, but not in the acute window. So in the Netherlands, and I think in some of the African countries as well, there's a feasibility of checking how the nerve is functioning. And I would recommend not to do it early on, because you need some time for the nerve to degenerate after an injury was caused. And only after this degeneration, which often takes like 3 weeks, there is a loss of excitability. So wait, be patient and wait. Although patients in the Netherlands, they are often very impatient and they want to have it as soon as possible. But your results are not so conclusive if you already do it early on. So in practice, when people come to my clinic, I often wait for about 3 months. Because in those first 3 months, you will not do a lot after those first few days have passed. We've been discussing this 3 days of going into a surgical case again, for example. But in practice, if you've passed this window of opportunity, I often wait like 3 months to see if there's some spontaneous healing. And then you can also do an EMG in the meanwhile. And then you can consider still in the months coming up if you need to do reconstruction. Also, it's quite interesting with this EMG, you can also check for the activity of the masseter muscle. And the masseter muscle is a muscle which is innervated by the trigeminus nerve as well. And this means that if people use the masseter to smile, and you can also check it tonight in front of the mirror, you can check, you smile, some people smile, and some people smile and they chew a little bit, so they bite on their jaws. And if people have this simultaneous movement, it's quite nice to use this masseter nerve if you need a donor nerve. So once you make an EMG, ask in a little note also to check for masseter activity while smiling. I wanted to put just one slide in for the classification. So there's 2 big classifications that you can remember. And the first one is the House-Bregman score. And that's, I think, which is most feasible in clinic, because it's a grading of 1 to 6. And in 1, you have a good function. And in 6, you have a very compromised function. And you can check, for example, those different stages, how it adds up. You can do it for a static, so if the patient is not moving, but you can also include some movements in it. But that already means that if someone writes down, for example, there is a house Bregman grade 3, you will not know if it's the eye or the mouth, for example, and if it was assessed while static observation or in a dynamic position. So it's a little bit a rough measure. But I think it's nice because it's quick, and sometimes we need to see a lot of patients, so then a quick estimation works really well. But if you want to go into more detail, you should check out the Sunnybrook classification. That also includes the synkinesia, so the movements that I just recalled. And then it also makes a difference between the steady phase, so static observation, and the dynamic movements. So if patients have a poor prognosis, we come to the idea of surgery. And that mainly counts, for example, for the elderly and then for patients with comorbidity. Also, of course, they are less ideal candidates for surgery. But also the patients who start with really severe House-Bregman scores and the patients in whom the EMG results are really bad. So if in those patients there's no recurrence of movement after 3 months, you could start thinking of a reconstruction. So for surgery, I want to show you this bike, and I show it to you, although I know that most African people know more about those ways of transport. But I want to show you this Dutch way of cycling, because this is the way many Dutch parents carry their children around the streets. And it makes it easy to understand what you need for the surgery. So first of all, you need electricity. So that's the motor we have here. And I compare it to the nerves that you need in case of facial palsy. So you can think of, is there a nerve available that I could use to innervate my wheels, which are the muscles? Because you can use your original facial muscles, but once they have been denervated too long, you can't use them anymore. So you should also add a muscle. And of course, the gracilis muscle, I think that's most commonly known. And then we come to the types of surgery, and I compare it to this ice cream because there's different flavors to it. There's static reconstructions, and I think especially for our colleagues overseas in the medium or less resource setting, you could use a lot of static procedures already because it may give a huge improvement to the patient. There are semi-dynamic procedures, an orthodromic transfer. I come back to that later. And then there's also dynamic reconstructions. Static reconstructions we start with. Static reconstructions for the eye can be distinguished from the reconstructions for the mouth. And there are several ways. So I think a big problem with the patients who have a facial palsy is that they will develop an ectropion. And for an ectropion, you can do many different techniques to improve it. Depends a bit on the way their ectropion looks. Some people have a medial ectropion, like this patient had. Some people have a lateral ectropion. It occurs a little bit more often. You can do it with a cantopexia, or you can include a tarsal strip cantoplasty. Some people, they need more suspension. So you can tunnel, for example, a tendon through the lower eyelid and hook it onto the medial and lateral canthal ligaments. Some people have a lack of thalamus because there's insufficient movement of the eye to let the upper eyelid close. And the upper eyelid itself is not innervated by the facial nerve, but the orbicularis muscle works as a muscle to contract the eye, and then the upper eyelid will go and fall down. And if the movement, so the onset of the movement, is not sufficient, you can make the upper eyelid heavier. So a little movement already is sufficient to let the upper eyelid close. And you can use a gold weight or a platinum weight. And I've even had patients who do not want to undergo this surgery, and they put it on a little weight outside, like with a steri strip, with a suture strip. You can even put it on or with some glue, and it may help from the outside to close the eye. And then there's another problem with the brow ptosis. So if your temporal nerve going to the frontal muscle is not working, you will have a brow ptosis. And the brow ptosis, up to a certain extent, is quite useful because it gives also some weight to the upper eyelid. So for some patients, having a brow ptosis is the savior of having sufficient eye closure. So remember, if you want to elevate it because it's giving too much compression, also the position of the upper eyelid will be different. So if you combine this surgery, you should first do the brow ptosis, so start up cranially and then work your way down, because it will all influence each other. If you do not take sufficient precautions with surgical options, but do not forget conservative options, of course, you will have very severe conjunctivitis, and it may be ending up in keratitis and loss of vision. So that is why it's really important to start with the eye. And once there's a fulminant facial palsy, just start with closing the eye with a tape or even with a suture, because we need to protect the cornea. I think that was enough for the eye. I continue with some procedures to the mouth. So this is a 72-year-old man. He had a facial palsy after a subdural hematoma a long time ago, and he came for a fascia lata slip. So it was suspended previously with a palmaris longus strip, which is done by some people. I don't really like it because it's such a tiny tendon. And also I like to have several strips. But I think it's not wrong to use a PL, but just my personal preference is to use a fascia lata sling. And that's what we did in this patient. This patient already had an incision in the nasolabial fold. And that means it was easy for me because I could enter it again. But in other patients, I try not to make it from the beginning onwards, but I try to make a nice pull up, and then the nasolabial fold will create itself again. So in this case, I harvested a trouser. And this trouser, there was first a position in the lower lip and then also in the upper lip, and then it was fixated on the zygoma. And this is one orientation. I will later show you also a comparison with 3 different strips. And that's actually what I use now, because I think it's very nice if you can put one strip to the lower lip, one to the upper lip, and also one to the side of the nose. Because patients, unfortunately, quite often have a collapse of the nose, the side of the nose. So with one additional strip, I think it's nicer that you can also open up the external valve of the nose. So here you see the effect of the pooling. You should always exaggerate a little bit, because we know it will fall back with gravity. And also from the upper side. So this is another patient. This is a woman, and she had a parotid gland cancer tumor. And in her, we knew it already beforehand. She also had a facial palsy also before the surgery. So that's how they found out she had a parotid tumor. And in this case, I also did a brow lift. You see here upstairs, and you see my marking of the gold weight. And then I also did those 3 strips of the fascia lata. And I make the incisions on the inside of the lip, and I try to avoid making an incision in the nasolabial fold. So if it's not necessary, I leave it. So this is the comparisons of the fascia lata strips, but also there's a temporalis myoplasty. And this is 1/3 of the temporalis muscle, which is tunneled towards the corner of the mouth. And if it's not long enough, you can make it a little bit longer from the beginning with a piece of the periost, but you can also get some fascia lata and make it a little bit longer. But we know that if you take all of the muscle, you can even get some movement in it, because you will leave the vascularization and the innervation of the muscle intact. And that's why it's called the orthodromic reconstruction. And that was one of the other flavors that I showed you. And the temporalis muscle, just like the masseter muscle, so the muscles of chewing, they are innervated by the trigeminus nerve. So those, I call them the semi-dynamic reconstructions. And in the literature, you can find them as the orthodromic reconstructions. So there's several different ways of approaching. So this is what you just saw, the Gillies technique. It's really old already, but it's not so good to get a functional movement. But it's nice because it's well vascularized if you include one of the vessels. But if you want to have some movement in it, it's better to do it in the way McLaughlin developed it in 1953, and then later on Labbé. In Labbé, he disconnected a part of the zygoma. And once you disconnect it, you can make from the inside also the coronoid process loose. and which makes you can really pull out the temporalis muscle down once you have incised it here at its origin. And for the McLaughlin procedure, he leaves in the zygoma, but he goes intraorally and then osteomizes the coronoid process. So I think these also for lower resources setting are perfect solutions for people who want a static or perhaps a semi-dynamic movement of the corner of the mouth. So then we come to the dynamic reconstructions. And I see we have like 10 minutes left. So I will go through it now. If you need a nerve and a muscle, you will get movement again. That's how the way I showed you previously. So in some people who have had denervated muscles for a long time, you need to also add a muscle. So the gracilis muscle is most often used, which is shown here. You need to do a microanastomosis, for example, to the facial vessels or also to your superior superficial temporal vessels, and you have to anastomose a nerve. For the patients who have parotid cancer, maybe a nerve is already enough, because if you select the best nerves, you can use them to re-innervate the own facial muscles because they are not denervated for such a long time. So this gracilis muscle, in this case with a cross-facial nerve graft, so a nerve graft, for example, from the sural nerve, branching off from one of the trunks here, crossing the face, and then later on, like 6 months later, you check for a TNL and you feel in its direction. And once you feel it has crossed the midline and it's going into the other cheek, you can add the muscle, and then you will also have a re-innervation of this cross-facial nerve graft, with the benefit also that there is some voluntary movement. It's not only this cross-facial nerve graft that we use. Sometimes we use the masseter nerve, I already mentioned previously. Like 20 years ago, the hypoglossus transposition was very famous. So if you use the whole hypoglossus, it will denervate too much of the floor of the mouth. So now we take a split hypoglossus, so leave in the majority, so only take out like 40%. And this is what you just saw, a cross-facial nerve graft, which is anastomosed to the obturator nerve. And then we come back to the slide that I showed you previously. So here we've seen that the facial nerve, at least its main trunk, it carries 10,000 axons. But if you take this obturator nerve to the gracilis, there is only 1,000 axons. So there is a big loss of axons if you only have the obturator nerve to get the movement back in the gracilis. And that's why we also try and think, can we get more nerves in? So sometimes we prefer to add some extra axons, for example, from the hypoglossus nerve, which has a lot of motor axons, or from the masseteric nerve, to get more power in this muscle. So sometimes you combine these techniques. So there are very many variations. I will skip this slide and I will show you some clinical examples. That's, I think, nicer, because there's many different ways to roam. You can have dual innovation, so you can combine techniques. So that's the cross-facial nerve graft. For example, here in the back you see it, and also this masseter nerve. Here again, you see this cross-facial nerve graft with the gracilis muscle. And then also the masseter nerve is used as a donor nerve. And we've now seen and learned that there are many more motor axons in the masseter nerve to give more power to the gracilis muscle. There are several ways of suturing. I think that's too much in detail for now. And then I take you to some photos. So this is the patient you've seen previously with his 3 different slips. We knew already that there would be a problem with the facial nerve because of the tumor involvement we could already see clinically. And what you see here is the zygomatic branch and the buccal branch. And I know that because I stimulate them during the surgery. And then from the masseter muscle, you see it here. The masseter muscle is quite nice, palpable. It's just below the zygoma. You can feel it here. There's a soft spot. And once you enter this muscle, you can find the masseter nerve. And you see here how I anastomosed it together. So I made anastomosis end to end of the zygomatic branch, also to the masseter nerve, and then the buccal branch I put end to side. So the zygomatic branch, because it goes to your eye, it's most important because we need this eye closure because we don't want the conjunctivitis or the keratitis. To anastomose it together. So this is the patient that you just saw. And I asked her to move. So I asked them to do different movements. And there I ask her to smile. And you can see she has to think about it. She's a young and very motivated patient, and she has done a lot of facial rehabilitation therapy. And you can see if I ask her now I ask her to close her eyes. But when I ask her to close her mouth, she thinks I have to bite a little bit. Then the masseter nerve is activated, and then it works. You also saw that she had some lack of thalmus. She wasn't able to close her eyes. So this is a later follow-up photo and also a movie. You can see I also did here a correction of her eyebrow, and I put in a gold weight. Because of time, I skipped the movie now. Maybe I show her, I skip the next movie. So I ask her to do the movements. You see the forehead, it lifts a little bit together with the right side. You see the closure is much better. You can ask a patient also to, if they go to sleep, that's the moment the eyes dry out, to close it manually for the last millimeters. The position is really nice of the eyelashes. And here you see a smile. So this is all masseter. This was a very motivated patient with a lot of rehabilitation by a meme therapist. So let's continue. So we make a lot of photos also to do some research with that. This is another patient who also underwent a tumor resection for parotid gland cancer. Here we took the auricularis magnus graft. So if this is a nice graft, you can see it on the sternocleido, you can use it as an interposition graft. But if it's not good enough, you prefer to take a sural nerve graft. And here it was sutured to the zygomatic branch. And because of time, I skipped the movie. So it was sutured to the zygomatic branch. And then my colleague did this case. He also to do a temporal myoplasty. So the eye comes from the nerve reconstruction, and the movement of the corner of the mouth comes from the McLaughlin myoplasty. This is a patient who came, I want to show you also, with an idiopathic facial palsy. And he presented because of synkinesia. So there was some recovery, but not sufficient. And then after 60 months, he came, which is quite late. And then I decided to treat the synkinesia. You can treat it with Botox. But I offered him also, this is the time, because after like a year and a half, you lose your functional facial muscles. If you want to do something, you should do it now with a nerve reconstruction. So we do the botuline to the orbicularis oculi. And then we did a masseter nerve branch. You've seen this technique before to get the reinnervation. So you really go and select the several branches. And this was the branch, these are branches going to the buccal system. So to create a smile. And here you can see the masseter nerve again. And we anastomosed it, and he's now in his recovery. So I'm really curious on how the gain will be in a few months' time. It often takes some 2, 3, 4 months to get some reinnervation, and longer if people are irradiated. And then don't forget about the ancillary procedures. So there's lots more to do. For example, Botox, I already mentioned. You can do myectomies, especially of the healthy side. So some people miss movement of the depressors. And the depressor is not such a very important function. So you can think even of getting some of the muscle of the depressor out on the healthy side to make a smile more symmetric. And also, but that's a little bit more advanced, we're not so far yet in the Netherlands, you can do a selected denervation. So if people have many synkinesias, you can selectively take out branches of the nerve, denervate the muscle, but it's of course a balance of not denervating it too much because you need this function as well. So it's done abroad and only for the very severe cases. So this is how I track it in the files. So I write down where I put the Botox in. So this was a left-sided affected patient with the orbicularis oculi muscle, where we put the Botox in for the synkinesia. And also at this side, some for the synkinesia, and at the cervical side, some people really have platysma bands caused by the spasm. And then also, because the brow was lower, you can consider lowering the other brow as well to get some more symmetry. And this is, for example, a case in whom I got it from the literature, in whom very small nerves are taken away, really to get a selective neurectomy. So I think there's two more cases, but considering time, I'm taking a look now at Francine. Perhaps it's better to check if there are any questions now. And if there aren't any, I can show you one big reconstruction case. It's always nice for plastic surgeon to go out with a bang.
Any questions, please? Maybe we continue with the big case.
So,
Then in case there are any questions,
thank you, Caroline, for a nice presentation. Dr. Kalan's here, Idris.
Hey,
Have
nice
you?
to see you.
Yeah, nice to hear from you. Do you have any experience with using temporaris muscle fascia for the eye?
Yeah, oh, no. No, so I myself, I really like fascia lata. So I don't use a temporal fascia because in my opinion, it's quite different among different cases how tight it is. And I know from the quality of the fascia lata that it's just really good. So that's why I like it a lot. And I think the scar is nice hidden. So I always take fascia lata also for the eye.
Okay.
I can imagine if it's a nice fascia, and of course, quite a lot of people have a nice fascia with its dual layers. You could consider using it.
Okay.
Have you used it before, Dr. Kalanzi?
Yeah, I trained with one of the best fascial nerve surgeons, Dr. Salim Beni.
Is it in Italy, I presume?
Yeah, Italian.
Yeah, nice.
So we used to use that.
Oh, good, good. And then you took the superficial fascia.
Yes.
Yes, very nice, very nice. It's nice because you have one area to work from. That's another advantage, not to having two areas just to do your surgery on.
Yeah, thank you.
Thank you. So let's go to this last case, because in big cases, you can consider using chimeric flap, and that's what I want to show you. And this is an illustration of a chimeric flap. So this is an ALT flap with the motor branch going to the vastus lateralis, and this is a chunk of the vastus lateralis muscle. So in patients who have a big tumor with neural involvement, so you already know that you need to resect the nerve as well. You can do a combined reconstruction of your soft tissue as well as putting a nerve graft in between. And the benefit of this approach is that you have a vascularized nerve graft. And there's not a lot of literature about it. So I really like the thinking of adding a vascularized nerve graft above a non-vascularized nerve graft in case of those big cases in whom radiotherapy is also expected. But for trauma cases, there's no evidence that there is a benefit of putting in a vascularized nerve graft. But for cases like this with a big tumor and also the need of radiotherapy afterwards, I think it's really nice to use this chimeric flap. So this ALT flap, let's see if I can show you. So a big resection was done by the colleagues of the ENT team. And here you see this chimeric flap, which you've seen in the illustration also in real life. So this is the pedicle of the descending branch going with a perforator to the skin and with a muscle branch to the vastus lateralis muscle. And here you can see the nerve. And this nerve can really nicely be used also to do reconstruction of the nerve. And here you can see how the nerve of the flap was used to reconstruct the zygomatic branch. And again, because this branch is most important to protect the eye. And then also the masseter nerve was nerve that we use as a nerve transposition to put to the buccal branch. And the masseter nerve you can try and activate with laughing. You will all try tonight to check if you use your masseter to smile. But that's the benefit of having the masseter nerve then to the buccal branch. And that means that with this reconstruction, you've solved your obliteration of the open spaces. So you will not have any cavities. You will have the reconstruction of the skin. And you will also have a new innervation going towards the eye and also to the mouth with the zygomatic branch and the buccal branch. And this is her then after surgery. So you can see with her, given her nasolabial fold, that she can smile again. And you can also see with the wrinkles around her eye and the sufficient eye closure, how good her orbicularis is functioning. So that was the last case I wanted to show you. I will not show you this dilemma, but I do want to point out that physiotherapy, like in hand surgery, is really important. So you're nowhere without a team. Like me here with my colleague, Dr. Smith, you might know, and this is our meme therapist. So that's really nice, whose son is training to be a plastic surgeon. So that's also really nice. And I think this is really stuff to do in a team. So thank you. So we took your question, Dr.
Thank you very
Kamatski.
much.
Anything else? Anyone else with consideration, thoughts, questions, ideas?
Any other question? Does Professor want to say something?
No, nothing. Thank you, Caroline. Very informative. And thank you, Titus, for coordinating this and Francine for organizing it as well. So perfect. Nice to see so many different people. So it's beautiful.